Welcome back, everybody. We are very, very excited for our next session. I know it's back to back, and we're happy you're here with us. Our next session is on genetics and colorectal cancer, understanding hereditary syndromes. And we are here with Sonya Grewal. Sonya Grewal received a master's specializing in genetics from McMaster University, then went on to earn a second master's degree in genetic counseling from the University of British Columbia. Sonia is certified by the Canadian Association of Genetic Counselors and has been a genetic counselor in the genetics clinic at North York General almost 20 years and played a key role in creating their familial colon cancer clinic. Over the years, Sonia has provided support and education to patients and families affected by various inherited cancer syndromes. Sonia is also a registered psychotherapist whose interests include working with patients and families dealing with hereditary genetic conditions. Without further ado, I will pass it over to Sonia Greywall. Thank you so much for being here with us.
That's great. Thank you. I will just share. So just give me 1 minute. Oh, I think that should be good. Everybody can see that okay? Oh, it's still not on the, hold on, hold on. There we go. Perfect. There we go. Perfect. I apologize. I have a bit of a cold, so if I stop for a few minutes to cough or drink water, I apologize. Thank you very much for having me again this year. So let's talk about genetics. What we're going to do today is talk a little bit about what hereditary cancer means, information about different types of genetic testing, how that testing impacts you and your family, and some of the genes that might be tested, and of course, who needs to be referred to genetics. So we'll touch on all of these topics throughout the talk. So just to start off, a little bit of background. We know that about 70 to 80% of colorectal cancer is what we call sporadic. What that means is there's probably small genetic factors that we don't know a lot about, things like hormones, chemicals, toxins, that all combine to cause one individual to get cancer. Only about 5 to 10% is what we call hereditary colorectal cancer. That means there's specific genes that we know about that will increase an individual's risk of getting cancer. And we're going to spend time on some of those hereditary high penetrance, meaning high risk of these cancers. Um, One thing to note is that not everybody who has a cancer diagnosis or a family history of cancer needs to be referred for genetics or even will be offered genetic testing. And hopefully, this talk will give you an idea of when it is important to get referral for genetics and genetic testing, and when it is likely more of this by chance situation occurring. So, what do we mean by hereditary cancers? Well, we know that when we talk about hereditary cancers, we're talking about our genes, and I'm not going to go over all the biology of it, but basically, genes are like pages in a book. They give our body directions on how to grow and develop. So, what color eyes we have, how our muscles move. And when we talk about genes, we're talking about those combination of letters I mentioned, and that's what makes up our DNA. And so when we're looking at testing for in our genes, we're looking at reading those combinations of letters, and we're looking for a mistake or what we call a mutation. And that tells us when we see a mutation that this gene is not working properly and not doing what it's supposed to in our body. So when we look at a family history, how do we know that we're suspicious of this being a hereditary cancer? Well, there's a number of different things that we're looking at. The one thing is we're looking at multiple generations and looking for multiple family members with colorectal cancer or individuals with multiple colon polyps. We're looking at the number of polyps and the type of polyps. I'm not actually going to go over the different types of polyps. I think in one of the other courses you're going to hear more about that. But certain polyps are much more aggressive, and others are much more slow growing. And so we want to see the number of polyps, but also the type of polyps that we might find. The age the polyps start developing. If we see polyps in somebody in their 30s, that has a very different meaning than seeing colon polyps in somebody in their 80s, for example. We're looking at the cancer diagnoses at young age, so under age 50, under age 35. That always raises our suspicion a little bit more. And then, of course, other cancers that might be linked to colorectal cancer, things like uterine cancer, stomach cancer, brain cancers. And then, of course, the last one is tumor pathology. So the type of pathology that we see in the tumor can help us guide us as well on whether we are suspicious of a hereditary cancer in the family. So who's offered this type of testing, this type of genetic testing? Well, each province is going to have very specific criteria based on their Ministry of Health. In Ontario, we have a program called the Provincial Genetics Program, which guides and supports what the criteria is for cancer testing and even what genes are being tested for. So in Ontario, we have the Ontario Molecular Genetics Labs where the testing is done. And that's often the same case in many of the provinces, but some of the province might send outside of their province for testing, for example, as well. In Ontario, we have the Hereditary GI panel, which is 31 genes. And for those in Ontario, that panel is actually increasing in the summer of fall of this year to be called the core panel, which will be about 40 genes. Um, when we look at a family history with cancer, what we want to do is we want to test the person that's going to give us the most information. And so what we like to do is try and test the person who's had the cancer first or the multiple colon polyps, because that's going to give us the most information for that individual and the family. And again, just a reminder that testing is not always indicated for all families. So what about the testing process? So what I want to first do is I'm going to break this slide down because I want to give a little bit more specific information about somatic testing and germline testing, because I think this is really coming up in a lot of reports and it can get a little bit confusing. And then we'll talk more in detail about each of them. So when we talk about somatic testing, we're talking about testing of the tumor, okay? And germline testing is usually testing that's done on somebody's blood sample. Now, if we focus just on the one side of the somatic testing, it's often started with testing the tumor because there are certain treatment options that might be guided based on what they find in the tumor. And so that's where testing originally started when we were looking at somatic or tumor testing. What we often find in somatic tumor testing is they will do these genetic tests on it. And when we find a mistake or mutation in this tumor, it tells us that that mutation is only in the tumor at that moment. We actually don't know where it came from. And we'll go over sort of how it can occur in the tumor. But a somatic test is testing done on the tumor and tells us what's in that tumor they've taken out. Germline testing is blood testing. That means that if we find a genetic mutation in the blood, that mutation is present in the egg and sperm. It means it's inherited from the family member before and passed down and can cause what we call the family cancer syndromes. And this is usually done on blood sample, but can be done through things like buccal swabs as well. So the most important thing about somatic versus germline or tumor versus blood sample is that not all somatic changes are inherited. Okay, so just because we find something in a tumor, it doesn't mean necessarily that it is in all of our cells and passed down from generation to generation. And when we find this tumor or mutation in the tumor, the type of gene change and the percentage of that specific change in the tumor guides us on whether we want to then proceed to blood testing or germline testing. We don't always need to do tumor testing. Sometimes, if a personal or family history of cancer or polyps meets the ministry's criteria, we can actually sometimes go straight to the DNA and gene testing in the blood sample. So hopefully that gives you a little bit of information, but I'm going to show you some other examples of how we differentiate between tumor testing or blood and germline testing. So this is another great way to look at how the gene mutations occur in a tumor. So in the top diagram, you see what we call sporadic. And if you remember from the first slide, that means the cancer is occurring by chance. What that means is that an individual cell, let's say in a colon, carries two of these normal working genes. So these genes are working properly, they're protecting the cell from growing out of control. Over time, that person's lifetime, in that one cell in the colon, sometimes something happens. It could be radiation, hormones, chemicals, toxins that damages one of those genes. So you can see from that picture in the center there, you've got one gene working and one gene not working. Often you're still okay. You're not at a higher risk of getting cancer yet, or in the sense that your cancer is not developing at this point. But then you wait 10, 15 more years, and that same cell in that colon tumor is affected again by these factors we don't know, where the second copy becomes damaged. Now you have two non-working copies in this one cell in the colon. That cell is no longer protected by those genes. The cell then begins to grow out of control to cause the tumor and the cancer. And so you can imagine if we test that tumor, we're going to see those two copies of those damaged genes. In the bottom diagram, you'll see what we call inherited or hereditary cancer. In this situation, an individual is born with one gene not working in all of their cells. Likely not just their colon cells, it's all of their cells, but sometimes we only see it in certain cells, in certain organs that are using this specific gene. So you're born with this one gene not working. Again, it doesn't mean you're going to get cancer, but now you need this one step for this other copy of the gene in that one cell in that colon to stop working. You then get the two damaged genes. That cell is no longer protected. It begins to grow out of control to cause cancer. Okay, so in the blood sample, you're going to see that first bottom left diagram where that one gene is not working. The next thing we want to do is talk a little bit about the type of inheritance we see in hereditary cancer, most commonly with the colorectal cancer genes. So this is dominant inheritance. And in the diagram in the or on the right side of the corner there, you'll see circles are biological females and squares are biological men. And I've just shown the sort of inheritance pattern of these genes not working. So in dominant inheritance, what it means is the one copy of the gene is an individual is born with it not working. So they have one good copy and one copy that's not working. And you can see the biological female on the top right first. She has one of each. So that means that every time they have children, they either pass down the non-working copy or the working copy. So you can have children that are affected or that carry this gene that's not working, or you can have individuals with two good copies of the gene. So just if it's not obvious here, the other working copy is coming from the other partner. So this is called autosomal dominance, and this is most often what we see in the colorectal cancers. And the genes we test for, I should say. The next one is called recessive inheritance. And in recessive inheritance, what happens is each parent carries the gene that's not working. It's the same gene that's not working. They themselves don't necessarily aren't getting cancer, but what happens is the tumor begins to develop when, not the tumor, I should say, the increased risk occurs when a child inherits both non-working copies. So an individual with this, we're going to talk a little bit about this, but in the recessive inheritance, these genes that occur this way, when you're a parent and you carry just the one copy, you actually don't have the same risks of cancer as you do when you carry both copies. And I'll show you some example of genes like that. So one is autosomal dominant inheritance, and this one's recessive inheritance. And we'll see that as we go through the slides as well. So just to come back to what we were talking about before, what does it mean when a gene is not working? Well, we did the blood test, it's DNA testing. You read the thousands of letters that make up that gene, and you're looking for a mistake. And so when we see a mistake that tells us the gene is not working properly, we call it a mutation. So when we do this test, we get usually three types of results. And I'm going to break down each of these results into positive, negative, and what we call variants of unknown significance. The first one is the positive results, and then we'll go through the negative. I probably should have divided this. I apologize. It's a little bit of a heavier slide, but if we just focus on the positive results first, and you can follow with the diagram beside it. A positive result means that a person doing this test has a specific gene mutation that we know causes cancer. Okay, so it could be, I think I've used MLH1 in this example. It's a gene that we'll talk about a little later called Lynch syndrome. And we know a positive result means that a person carries one of these MLH1 genes that is not working. And what that means is that it's a conclusive result. We know that this gene will increase the risk of cancer in an individual. Now, if we test in a person who has cancer, we can correlate that with that individual's colorectal cancer. So we know what caused that individual's colorectal cancer. We can then talk to the individual about what cancer risks are elevated because of that. So certain genes will have they'll work differently in different organs, and therefore certain organs are at more risk at certain cancers, and certain percentages we can give them based on the gene that's not working. We can then test other family members to see if they carry this gene and are also at increased risk. And we would give screening recommendations based on this specific gene mutation that's not working in this family. Now, when we think about the negatives, I'm going to give you two examples of negatives. They're still negatives, but I want to show you the difference of what it means. A true negative is when let's say your parent carries this MLH1 gene that's not working and their children are being tested. And the one individual gets tested and is does not carry that mutation. That's called a true negative because we have identified the cause of the cancer in the family member. So we know now that if this child does not carry the same gene change as the mother, let's say in this case, or the father, then we know that they are true negative and they did not inherit the gene that's causing the cancer in the family. So we call that a true negative. And sometimes this gene may not explain all the cancers in the family, so we're still going to talk about some other screening options that are available. An indeterminate or uninformative negative is still a negative, but an example of that might be an individual with colon cancer gets testing for these 31 genes and there is no mutation identified. So these 31 genes I mentioned, we do not find any of these genes, no mutations, so they're all working properly, and we tell them that, well, you are negative for these 19 genes, which means that none of these genes have caused your cancer, which is great. It reduces their risk of having this sort of inherited cancer. But what does it mean for that individual? It means that it's less conclusive. We know that these 31 genes didn't cause the cancer, but it could be that there's another gene out there we haven't discovered yet because we don't know what all of our genes do. So we can never say that it's not inherited. We just know that it's not one of these 31 genes. It also could be that maybe the cancer was occurring by chance. It's what we call sporadic. So a number of things that just came together for it. So there's still a negative result. We still wouldn't test their other family members, like their children, for example, because if the 31 genes we're testing for, there's no mutation. We're not expecting to find anything in the children. It doesn't skip a generation that way. And of course, screening is still important because we want to base it on the individual and family history of cancer at that point. So the third result is what we call inconclusive, and you'll often see a report that says variant of unknown significance. What that means is an individual carries a gene change that we don't know a lot about. So when we see changes in the genes, we all carry changes. It's what makes us different. But certain gene changes, once we see them, we do lots of different types of testing to identify how they affect our bodies. So some cause harm, which is why we call them pathogenic or positive mutations, meaning they cause harm, they're causing our cancer. And some are negative. We know that their difference is that we just all carry. These variants of unknown significance fall in between there. They are changes we haven't seen, let's say, a lot of or done a lot of research on. And when we label it as VUS, we still treat it like a negative. We don't test other family members necessarily, but what it means is that we just don't know how it affects our bodies yet, and we need more research. So what we often tell our patients is to contact us every 3 to 5 years, let's say, and say, they'd call me and say, Sonya, I had this unknown result. Any new information? I would go back to our databases to see if there's new information that has reclassified it. At some point, it will get reclassified. We just don't know if it's in a year, 5 years, 10 years. It all depends on how many people are identified with this genetic change and how much research has been done on it. Of course, we treat it like a negative, but screening, of course, is still important, and we base that on the individual and family's history of the cancer. So next, what I want to do is start a little bit of information about specific genes in colorectal cancer. So what I've done here is it's a very big picture of different genes that we do often test for. Again, it's going to vary from province to province, but these are some of the more known genes that are out there in the literature that a lot of provinces are testing for. And I've just grouped them into things where we get primarily colorectal cancer, primarily maybe colon polyps, and then some of these other genes that are actually usually tested for other reasons, but they come up because at some point in time, there's been some risk of colon cancer. We're going to focus not on all of them, just some of the ones that I think are important that come up more often. So the first set I'm going to talk about is the genes that are involved in Lynch syndrome. And I think most of you are probably familiar with Lynch syndrome as it's one of the first set of genes we've known about for a very long time, but I'd like to review that just to make sure we're all on the same page. So with Lynch syndrome, one of the interesting things is this is where somatic testing actually is one of the first places it started before we even knew about all these genes. And so with colorectal cancer in Ontario, anybody with colorectal cancer will have their tumor tested for immunohistochemist. Sorry, this is my cold coming out. Immunohistochemistry testing. So we'll just call it IHC while I'm sick here. So IHC testing. I don't know if all the provinces do it all the time. They might have age thresholds, for example, before they do it. But what this does is they're looking at the tumor and they're testing it for the absence or presence of certain proteins. When I talked about the genes give instructions to make proteins, and the proteins then give instructions to our body how to function. So what they're doing is they're not looking at the genes at this point, but they're looking at the middle at the proteins. When the protein is absent, or sometimes you'll see in the reports, they might call them not intact, and if absent, not intact means that the proteins aren't showing up in this sort of I call it like uh, it's not coming to me, but it's like a color test almost in a way. So when it doesn't present itself, it's absent. And that usually leads the doctors to suggest germline testing because it tells us that maybe some of these genes aren't working properly and we want to do a blood test to see if the cause of the cancer is one of these Lynch genes. The left side, I'm not going to go into too much detail, but sometimes the proteins, if they're all present, they may not indicate further testing. But of course, that depends on the family history as well. Can these proteins all be present? And of course, there's a number of other genes that can be tested for. So it really depends on the family history as well. But this is one of the first places you'll see some IHC testing done on a colon tumor. So, what do we know about Lynch syndrome? Of course, Lynch syndrome is one of these most common conditions that we know about. They're caused by those genes that I mentioned. They have a number of different risks. Before I go into Lynch syndrome, you'll see the circle there with the two chromosomes and the two genes there. When I talk about the genes, I'll show you that just so you know that this is an autosomal dominant inheritance, where an individual only needs one copy to be at a higher risk of cancer, and then it's a 50% risk to pass it down. So when we look at the Lynch syndrome genes, the highest risk for colorectal cancer is with the MLH1 and MSH2 genes. So I've used the highest risks here, but for each gene, there is different risk numbers. And if you have one of these genes not working, your genetics team would give you much more specific information based on the gene. But the colorectal cancer risk is up to about 61%. We usually talk about a colonoscopy starting at age 25 years of age and every 1 to 2 years. You might do them more often if you're getting a lot of polyps. There's a high risk of uterine or endometrial cancer, up to about 60% risk. Often individuals with this gene that's not working, as they get closer to menopause, women will be suggested to have their uterus removed. Ovarian cancer, up to about 40% risk. Again, often closer to menopause. If you're having your uterus removed, you may recommend the ovaries as well removed at that point. There are other cancer risks associated with Lynch syndrome. We're looking at stomach cancer. Sometimes you'll do an upper scope as well, brain cancer, pancreas cancers, and different screening recommendations based again on the family history. There are some different pancreas screening, but again, very specific based on the family history if you're eligible for that type of screening. Sorry, excuse me. So I was talking about Lynch syndrome, and we talked about the genes that are involved in Lynch syndrome. What I want to briefly talk about is what we call congenital mismatch repair deficiency. This is caused by the same Lynch genes. It is not Lynch syndrome. And what happens is an individual inherits two copies of these Lynch genes that are not working. So again, you'll see the circle on the top there, and both genes are not working, and it's a recessive condition. So in this case, although it's caused by the Lynch genes, we don't call it Lynch syndrome. It's called the CMMRD condition. And you'll see a much younger age of onset of cancer. So it's not a very common condition. I think there's a group in Toronto that follows these patients. There's about 80% of people will develop cancer by the age of 18. And most of those cancers, the first ones that are initially diagnosed, are colorectal cancers. You'll get brain tumors, leukemias, lymphomas, multiple colon polyps, all observed in young children. So the first age of diagnosis of any of these cancers is usually between 5 and 28 years of age. And of course, this is occurring only when you inherit two copies of the Lynch genes. So often, if a parent carries Lynch syndrome or has this gene for Lynch syndrome that's not working and they're in their reproductive years, the partner is often offered testing for this to see if their children are at risk of inheriting two copies and getting this CMMRD condition. Okay, so that's a little bit about Lynch syndrome. So let's talk about the next set. And this is a set of genes that are primarily the highest risks are for colon cancer. And so again, I'm not going to go through all of these, but I will mention a few of them. So ones that I talked about last year that were actually newer in the past, so they're not as well known as Lynch syndrome genes, but are still now, are coming in the more known category, is the Pol E and Pol D1. So these are actually within the same um, sorry, this is my brain fog here, in the same lineage of the how they affect our bodies. And so that's why they're similar in the way they function. They have I missed a percentage there. They increase a greater than 20% risk of colorectal cancer. And they do show colon polyps as well. The risk of other cancers is still not clear yet. And that might change over time. The more cases we see with this POLI and POLD1, the more we get to know about it, we might see correlations with other cancers. But right now, they're not really saying there's a risk of other cancers at this point. And the recommendation, if you carry one of these genes not working, is a colonoscopy starting at 25 to 30 years of age. And again, every 2 to 3 years if no polyps. If there's polyps, you're going to do them a little bit more frequently. So the next set of genes within this category are syndromic conditions with colorectal cancer and polyp risk. So syndrome just means a group of signs or symptoms that consistently occur together. And so all of these conditions I'm going to talk about here are autosomal dominant conditions, and they tend to occur at a younger risk than Lynch syndrome, for example. So there's some consistencies around them. And one of the things you'll notice with all of these, other than P53, is a higher chance of a very specific type of polyp called the hamartomas polyps, which again, I think you're going to get a talk on some of the different polyps, and they'll talk a little bit more about that. But when you see pathology and you see these types of polyps, often the pathologist might even suggest this about some of these genes being tested for because they're very specific to certain types of syndromes like this. So you'll see like in the first underlined one is BMPR1A and SMAD4, which again follow the same lineage in terms of how they affect our bodies and where they are in our system. And they show like a high risk of colorectal cancer, a few of the colon polyps, and a risk of some of the stomach and pancreas cancer. To the right, on the top right, is the STK11, the Peutz-Jeghers syndrome, PJS. Some of you might familiar with this. There's some pigmentation on the lips. I must have taken out the diagram with it. There's some lip bindings on that as well. I think I took it out in the one that I'm giving you, but I maybe put it in your in the one that I gave out earlier. And there's a risk of colon cancer and a risk of increased risk of these specific polyps as well in the GI tract. And then, as I mentioned, the pigmentation on the lips, you can also see them in the vulva, fingers, toes. And that usually, sometimes through a dermatologist, we get referrals even because of this. And then we get more knowledge about what their risk is for colon cancer. The other two are very different. P10 and P53, or Cowden syndrome and Leishman syndrome, they have actually a lot of other factors involved. And I'm not going to go into a lot of detail, but in Cowden syndrome, we'll see colon cancer, colon polyps, a larger head size, other benign and malignant tumors in thyroid, breast, kidney, endometrial. P53 is a full body diagnosis, often involving needing MRIs over long term for the body. You'll see increased risk of colon cancers. It's not really associated with colon polyps and multiple other cancer risks as well. Again, for these ones, generally when we're looking at colonoscopies and endoscopies, we're starting in the teens, maybe about 15 years of age, every 2 to 3 years. The third category, there's actually two new genes that we are in Ontario we are testing for, and I think they're going to be coming out in some of the other provinces as well. So these are mostly polyposis cancers. So the one that, again, most of you may be familiar with is the APC gene. We get the classic AFP, over hundreds of adenomas at young ages, sort of carpeted in the colon, removing full colons at times. The AFP, which is the attenuated familial adenomatous polyposis, is still caused by the APC genes, but again, it depends on the family and what's happening in the family. Do we call it AFAP, the attenuated version, or the classical version? And so what happens is you still get lots of polyps, but you don't see the same carpeted that you see in the FAP. And the average age is slightly higher than you see with the classical FAP. You'll see a number of different other cancers, stomach, small intestinal cancers, papillary thyroid cancers, differences with teeth, sort of extra teeth, jaw tumors, benign jaw tumors, bone tumors. And then there's this chirpy, which is the congenital hypertrophy of the retinal pigment epithelium. And so sometimes we get referrals from actual ophthalmologists because they find that first before they know about these higher risk of colon cancers. So sometimes we get referrals from other than colon surgeons to us. And again, colonoscopies are starting at a younger age, 10 to 15 years, and every year. So one of the polyposis conditions that is recessive, so again, if you see in the corner, you got two genes that are not working here, is MAP syndrome or MUTYH. This is very similar to FAP, but it's a recessive inheritance. You'll get the 100 colon polyps like you do in the attenuated FAP. You'll get colorectal cancer, again, slightly older than the classical FAP, so not necessarily in the teens. And you'll get sometimes the duodenal polyps, which is sort of the area between the stomach and the small intestine as well. So in this case, we often recommend colonoscopy starting at 25 to 30 years of age and every 1 to 2 years, and also an upper scope as well for those other types of polyps and cancers. Um, Here you'll see the MUTYH heterozygote is when you carry just the one copy not working. And we talked about that, when we saw that recessive inheritance, the parents carry the one copy not working, they pass down both copies to the child. We don't know a lot about the MUTYH heterozygotes. We don't think there's a higher risk necessarily, but what we do is we do suggest colonoscopies every 5 years, beginning at age 40 and 10 years before the onset in the family. So really with individuals that carry just the one copy of this gene change, what we would do is we would actually suggest looking at the family history to give the best recommendations. But generally, it's about 5 years, beginning at age 40 or 10 years before the earliest age of onset. This one is a newer gene change that a gene that we are testing for in Ontario. So it's in the fall, it's coming out. It's called the MBD4, which is the associated neoplasia syndrome, or Mann syndrome, it's called. It is a recessive condition, so it's like the MUTYH, where you get both genes are not working. You'll get 15 to 100 plus colon polyps, beginning colonoscopies at 18 to 20 years of age, every 2 to 3 years. Other things that you might find with this gene change is AML, or acute myeloid leukemias. You'll see uveal melanoma, so melanoma in the eye. And you'll also see something called, sometimes, again, some studies are suggesting it, this unilateral or bilateral schwannomas. So what these are they're benign tumors that are formed from specific cells that line and support the peripheral nerves. So you'll like some movement issues or nerve issues, and that's where it gets flagged sometimes. Again, the heterozygote, which means only an individual, like a parent that carries one of these copies, the risk is unclear if there's any other risks, if there's any risk for individuals that only carry the one copy. Again, as we know more about it, we might change some of the screening. So the colon screening for this might be based on the family history at this point. Another gene that's being introduced this year is called AXNIN2, and it's called oligodontia cancer syndrome. So it's mostly a polyposis. So, we talked about certain genes cause more polyps than they do cancer. If you leave the polyps in long enough, they're going to cause the cancer, obviously. So, but we see lots of polyps in this. And the difference with this one, it's autosomal dominant, meaning you only need one of these genes to not work. And there's what we call dental markers. So there's a congenital absence of 6 or more teeth, and that doesn't include the wisdom teeth. Some studies will suggest an increased risk of prostate cancer, other skin cancers, as well as abnormal development of skin, hair, teeth, nails. They're called ectodermal dysplasia. Again, recommendations is the colonoscopy is starting at 25 to 30 years of age, every 2 to 3 years unless polyps are identified. Often, again, this might be identified through a dentist. So we might sometimes see a referral from a dentist and then letting the family know about this colon cancer risk. So these are some of the polyposis genes. At one point, we thought they were more common. So I'm calling them rare because I rarely ever see these gene changes. The way we discover genes is that there's lots of studies on different genes, how they affect our bodies. We do studies on families that have these cancers, and then we start looking to see if there's a correlation. And so historically, these are some of the genes that I've reported last year as well. MSH3, MLH3, and NTHL1. These are recessive conditions. Again, you have to have both copies in order to have an increased risk of these a higher number of colon polyps. And so we test for those as well. RNF43, that came out a few years ago, and the thought was that that was really going to be the main cause of all these serrated polyps. So serrated polyps, again, you'll hear they're much more flat against the colon, and they're harder to actually sometimes remove and see because they don't pop out as much like the other colon polyps. And so at one point in time, we thought this was going to be the gene change that was going to be causing a lot of these serrated polyps in these families. And this is actually one of the polyposis genes that's dominant inheritance, but it's still limited to only a few families. We still don't see it very often, but in Ontario, at least, we still test for all these four genes, and just to rule it out because we know it has been seen, and so we don't want to miss those one or two families that we might see it in. And again, with these genes, these polyposis genes, we know at this point in time, no other cancers are associated with these genes. It's just the higher risk of colon polyps. So when do you ask for a referral to genetics? So, we've talked about personal history of colorectal cancer or pathology on tumors. So often when you have, again, it varies from province to province. So I don't want to say one thing and different provinces might be a little bit different. But, if you have a colon cancer under the age of 50, and you have this tumor showing IHC non-intact, meaning that some of these proteins don't look like they're functioning properly, that automatically is usually a referral to genetics for us to rule things out. And we'll look at the larger family history. In genetics, we do a 3-generation pedigree. We look at the family history to see what other cancers might be related to help us identify what we want to test for. So that's one obvious path there. Another way is if you have a number of colorectal polyps. So let's say there's no family cancer of history. You've had some GI issues, you start having colonoscopies at 30, and you're seeing some polyps. Well, again, polyps aren't unusual. We know that we do see some polyps in everyday people. The concern becomes if every time you have a colonoscopy, you keep seeing these polyps, that's sort of a red flag. And so if a person has a number of colonoscopies or even one or two where over 20 of these colon polyps are being identified, then that's usually a quick referral to genetics as well. Because that is not what we would consider within the normal range kind of idea. And then the next one is if you have a personal and family history of multiple cancers at a young age. So this is for an individual who's going to let's say their family doctor. They see that, I've got a number of people in the family with cancers. Maybe I don't have cancer even, but we see a lot of colon cancer, colon polyps, or you have an individual with colon cancer at the age of 70. IHC is intact, everything looks good, but you have this huge family history of other cancers, a lot of colon polyps. So some of the cancers that might be related to some of the colorectal cancers and those genes are uterine cancer, ovarian cancer, pancreas cancer, stomach cancer, kidney cancer, brain cancer, skin changes. So, if your doctor is seeing a lot of that, they might refer you to genetics so we could do a better look at the family history. And then, of course, one of the referrals now, since we've been doing genetics and gene testing for a long time, is that the number of genes we test for, the panels we test for change over time. So in Ontario, for example, if you had genetic testing before 2016, we often suggest a referral back to genetics because there's a lot of new genes that are being tested for since then. So before 2016, most of the ones we would limit to Lynch syndrome genes. So after that were some of the other genes we've talked about. And then as you can see, in the fall in Ontario, there's even more genes coming up. So we say generally after 2016, if you were tested before then, to get referred back. And I think that would apply to anywhere across Canada as well, because these are genes that were discovered after the Lynch genes, and so may not have been part of your early panels. So just a few things that I think are important for the group to remember. Um, New technology continues to develop. So, we're always identifying new genes, not just for colorectal cancer, but even in general for cancers. We're identifying new genes, and sometimes we might have studies being done and we find a gene for breast cancer. But the more families we look at, the more individuals we're seeing, we're saying, oh, you know what? There might actually be some correlation with colorectal cancer. So this technology, by looking at genes, even with other cancers, we're finding new genes that are involved in colorectal cancer. So if you remember that diagram I showed you with lots of different genes, some of the genes were found through other cancers, predominant cancers. And even though the risk might be a smaller risk of colorectal cancer, there's still genes that we want to help identify in families with colorectal cancer. So that's really important. So that's why it's always good to keep in touch with your genetics team. If you've been tested years ago, ask about new genes being. If you hear about new genes, contact your genetic counselors or your genetic team to say, hey, should I be getting more testing done? Um, your doctor can refer you to the closest genetics clinic if you meet criteria for not just genetic testing, but for genetic counseling. So sometimes the doctor may not know you're eligible for testing, and they might say, okay, I'm going to send you to see a genetic counselor. They may or may not order genetic testing. So I mention that because sometimes people will get referred to genetic counseling or a genetic center and they are surprised that they're not offered genetic testing. So just to note that like a preliminary sort of screen. Okay, let's send them there. Let's take a family history. Let's get more information. Wait times may vary across the clinics and the provinces. And so because genetics is really increasing in cancer diagnoses and supports, what's happening is that we get a lot more referrals throughout the genetic centers, but the genetic center numbers aren't necessarily increasing. And so we do have to prioritize a little bit. So often the people who have had cancer or are waiting for genetic testing to identify different treatment options, we'll prioritize them, get them seen as quickly as possible because treatment's going to be really dependent on that. Individuals with family histories or known mutations might get a little bit also prioritized. So, there might be some variation in wait times, and just to be aware that we haven't forgotten about you, but we are trying in Ontario to actually get even, and this might be occurring actually in a lot of different clinics where people with cancer, their surgeons and their oncologists are able to order some of the testing now, and we call it mainstreaming. So they bypass the first genetics appointment and get testing through their surgeons or their oncologists. And what'll happen is if there's a concern on that report or they feel like they still are missing something, then they'll refer to genetics for us to follow up on. And so the purpose of that mainstreaming is to actually get individuals with their cancer and waiting for their treatment, for example, or surgery, to get them fast tracked a little bit more quickly and not get stuck in sort of the wait times in the genetics clinic. And so myself, for example, I give talks all the time to surgeons and oncologists to help them understand that they can order the test, how it's done, and why that's important so that we could bypass that wait time a little bit. And for those that are waiting for an appointment in genetics, what I really suggest is, gathering as much information as you can about your family, the type of cancer diagnoses in the family, the age of diagnosis. Those are the things the genetic clinic wants to ask. The next point is if you know there's a mutation in a family, making sure you have a copy of that report when your doctor refers you to genetics. You'll need that report in order to get testing done. I apologize. And then the final thing is, as I mentioned before, if you have a genetic test that shows a variant of unknown significance or a negative, to touch base with your genetics team every 2 to 5 years. And I'm going to leave it at that. So I'll just end there. Thank you very much.
Thank you so much, Sonia. We appreciate it very much. Not just the information, but your commitment to our community being here so unwell. So thank you so much. We do appreciate it. To our silent viewers, again, we ask that you head to the lobby so that you can join the next session. I do note there'll be an additional 15-minute break, so 4 p.m. Eastern time is when the next session starts, just so you're aware. And then coaches, if you can head into the backstage so we can continue on with our question period. We'll see everybody soon.